We're going to be discussing, as Peri-Ann walks us through her presentation and answers any questions that you have, the topic of a person and family-centered approach to long-term care home admissions. Peri-Ann has been the social service manager at the Perth Community Care Centre since September 2021. Her main responsibilities include admissions coordination, providing social work services to residents, their families, and staff concerns, suggestions and procedures, facilitating care conferences, working with the behavior support team, and overseeing the recreation department, co-chairing the Joint Health and Safety Committee, and being the home's BPSO lead. You are a busy person, Peri-Ann. This presentation is the last deliverable so that their home can receive their official BPSO designation in March of 2026. And we congratulate you, Peri-Ann, and your home on that designation for March 2026. That's very exciting, and I know a lot of work has went into that with you and your team. So thank you for being here, and I will hand it over to you.
Thank you. Yeah, thank you for the introduction. So I'd like to start off by giving a bit of a background as to our home and our home's history, just so that everyone has a sense of kind of where we're coming from. So as you can see in the picture there, our home was originally built in 1902 as the Lanark House of Industry. So we have a lot of history. And over those years, we've been a private hospital as well as a nursing home before finally becoming an official long-term care home. We're located in Perth, Ontario, which is between Ottawa and Kingston. And we're known as a bit of a retirement community because oftentimes people from Ottawa or Kingston retire to Perth because we have such a beautiful area with lots of lakes and rivers, with the Rideau River going through as well. We're currently licensed for 121 beds, but in the old section of our building, we do have some ward rooms which would have had 3 or 4 people in them at a time. And during COVID, of course, they closed those. So a maximum of 2 people could be in those rooms now. And so our current maximum occupancy is 110 beds, but we have received approval to have a new building built, which is very exciting. No official word on dates yet, but we do know it will be licensed for 160 beds, and it will be right next door to where our current building is on the adjoining property. So we look forward to that coming in the future. Okay. So our journey with BPSO started in September of 2021, and we've implemented 5 different best practice guidelines. And I just want to give a quick shout out to my teammates. So I have taken the role as the BPSO lead, which is a bit unusual. It's usually a director of care that takes the lead, but we've gone through several different directors of care. So our current director of care, Jennifer McElwee, has been a wonderful asset to the team and has kind of taken a bit more of a backseat position because she's relatively new. But really, Darlene Lawler, who is my RI coordinator, has been really the backbone of the BPSO team, as she's been kind of the one constant because I was gone for a little while on maternity leave. So shout out to her and all of the hard work that she and the team has done. And as you can see, we do have a really good multidisciplinary team for the different best practice guidelines that we've implemented. Otherwise, I'll move forward here with, you can see this is in our hallway of heroes, where we highlight all of the different staff training that our staff have completed. So all the stars on the board there are our different staff that have done their best practice spotlight champion training. And we've had 39 staff complete it so far, but we continue to recruit. We've got a new onboarding process and orientation process where I go in and speak with the new staff on joint health and safety and a few other things, but I also talk about BPSO and try to recruit more champions that way. I also highlight this board when I'm doing tours for new admissions or anyone coming to check out the home, and talk about our BPSO work, and provide them with a pamphlet during the tours, as well as I mail them out in the welcome letters, which I'll touch on a little bit later on. So of course, we started with our gap analysis, looking at person and family centered care. And to give a little bit more context as to where we were at when we started this, our home had had a significant staff turnover. And because of the number of vacancies, that kind of resulted in us being on a cease of admissions for quite a while. So we had about 30 beds vacant when I started. And so there was a really big focus on the admissions process and having to fill those beds and get up to occupancy. And so that's when we really started this process of completely overhauling the admission process. And what we found when we looked back at what we had been doing is that it was not person and family centered. The information that was gathered was not being shared in a very cohesive way. And so each department was kind of asking the same questions, and it was very repetitive. And then sometimes important information was being missed. So it was being, we were being reactive instead of proactive, which was really not ideal. And because of that, care plans were not personalized to what they could have been. And residents and substitute decision makers were not as involved in creating their plan of care. And so we really needed to do a lot of education with our staff on person and family centered care. So in overhauling this admission process, we came up with a new application review tool. That is what I use when I receive an application from Ontario Health at Home through HPG, which is totally holistic and gets a really good whole picture of the person. We started doing pre-admission care conferences where I would invite the resident or the substitute decision maker to come into the home, have a tour if they haven't already had one, and then go over all of the application information I had collected and fill in any gaps or correct anything that wasn't necessarily totally accurate. And then once we filled some of the vacancies in our team, we were able to restart doing those admission, annual, and significant change care conferences, and start implementing the resident wishes and goals of care conversations into those conferences. So one of the things I'm going to really highlight is our application review tool, which is also used as a 24-hour care plan. So as I mentioned, I use this to review all of the applicants. And if I have any concerns or questions about the applicant, then I refer it to my director of care for review. And then once we get all of it approved, we can proceed with the bed match. And once that's done, then during that pre-admission care conference, it's again reviewed and updated. I also use this tool and kind of select the different relevant pieces to send it out to the appropriate departments so that everyone knows that, Betty Smith is moving in tomorrow. This is what you need to know about her. She's deaf in her left ear. Make sure that you're speaking on this side. Just kind of the general information, nothing too confidential. But then the full application tool is in the residence chart and is on the floor as soon as possible once the bed has been accepted for everyone to review, and then is reviewed for 3 days following admission to make sure that the team really knows who it is that they're caring for. So the different sections in this tool there's 12 different categories. So it goes over their basic demographics, their consent capacity, whether they're capable or incapable, medical history and allergies, their functions of daily living, dietary history, their abilities when it comes to activities of daily living, their continence, risk is a big section, medications, infection control, and then the person and family centered care piece. And then of course, just finalizing it in that I've reviewed the application and so has my director of care. So the first two sections, as I mentioned, are those basic demographics. So their name, how they would like to be addressed, their ID number in point-click care. Where are they coming from? Is it another long-term care home, the hospital? What are the specifics there? Their primary contact, is the person capable, or is there a substitute decision maker you would be contacting? Their current physician, so before coming to the home, and what physician are they going to be assigned to upon admission? Is there any current involvement with external care partners like Jerry Psych, other things like that? When are they coming to the home? What date, what time? What room are they going to be admitted to? And then, of course, their consent capacity and all the things that kind of go along with that. For medical history, any relevant diagnoses, anything that's included in the paperwork we receive for the application, any allergies or intolerances we need to be aware of. And then we get into the functions of daily living. So cognition. So if there's any MOCA scores, mini mental scores, CPS scores, those are all really good to include in there, as well as if there's any reports of sundowning. Sleep and rest. So getting some of the person and family centered routines, are they a person that likes to typically stay up late watching TV and then sleep in? Do they care if they sleep through breakfast? Maybe they don't. So those are things that are important to capture. Vision. Is there anything we need to be aware of with their visual abilities? Is there any aids that they require? Their language preferences, and then their communication abilities. So do they require any communication tools like boards or pictures? Do they typically understand things that are being said to them, but maybe have difficulties expressing themselves or word finding? And then hearing, as I mentioned before, are they, hearing impaired in one ear over the other? Do you need to make sure that their hearing aids are applied, and do they need assistance with that every morning and then taking them out every evening? And then their oral abilities. So if they have dentures, are they full or partial? Do they have any preferences when it comes to oral hygiene? Do they have any complaints with, dry mouth or difficulty chewing? Those are important things to capture. And then dietary history. So do they have any specific dietary requirements or restrictions, like being gluten-free? Do they require a modified texture or thickened fluids? You can also capture any preferences or dislikes, as well as any supplements like a boost or onshore. And then we also capture their height and their weight and their BMI, so that if there's any specifics with regards to bariatric equipment, you can make sure that you have that all in place before they arrive. Then we get into the activities of daily living. So what are their hygiene practices? Do they typically brush their teeth once a day, twice a day? Do they see the dentist religiously? Maybe there's a fear of dentists. Personal hygiene, what level of assistance do they need? Do they have any preferences when it comes to applying makeup or jewelry? You want to make sure you're honoring that as much as possible. And then eating, what level of assistance do they require, or do they need any adaptive aids? Bathing, any past practices or routines, like oftentimes we'll get farmers who absolutely will not shower in the morning. That's a waste of a shower. They want to shower in the evening because, of course, they want to be clean for bed. And things like that can really help when it comes to resisting care. When you look at their routines, you can kind of be proactive instead of reactive in that way. Bed mobility, do they require a scheduling repositioning program? Do they require a scheduled toileting program through the night, or do they need any assistance in that regard? When it comes to transfers, again, do they require a mechanical lift, or is it one person or two person assist? Is there like a transfer pole so that they can do that themselves independently? Mobility, what personal assistive devices do they use? And do they need assistance to do that? And when going on and off the unit, or transporting to different areas of the home, do they require assistance in that regard? Then we get into the continence section, where we look at the bladder continence, continence of their bowels. Any issues with diarrhea or constipation should be noted. Do they use any continent products, and what type and what size, if you can find that out? And then the catheter or ostomy, if they use those, and what size, what frequency of change you would need. Then we get into the risk assessment. So we look at their mood. In their diagnosis list, do they have any history of depression or anxiety? They might not necessarily have that, but then in the inter-eye HCA, they might have symptoms of depression or anxiety. Is there any noted behaviors in the behavioral assessments? And you can include, all of the different circumstances and successful interventions. Alcohol and substance use is good to be aware of ahead of time, or if there's any history of that. Any psychotropic medications. Their risk of harm to self or others. Is there a history of suicidal ideation or attempts? Have they been physically violent towards others? Is there a risk of wandering? Specifically with our home, we don't have a secure unit, so that's something we really have to watch for and make sure that we're able to meet their needs. Their level of falls risk, so that we can put in any falls prevention measures ahead of time so that we're not waiting until a fall happens to implement those things. Pressure injuries, do they currently have any pressure ulcers or sores? And if so, what are their dressing change routines? Any skin issues? Do they have psoriasis, rosacea, other wounds that we should be aware of? Their pain risk, do they have, are they prone to right shoulder pain? Things that you need to be aware of when assisting with, dressing, for example, or transfers. And then is there any other special nursing treatments like oxygen or dialysis? Then we get into the little medication piece. So their current pharmacy, our home uses CareRx, and we do a boomer document so that the pharmacist and the doctor taking over their care do their thing behind the scenes, which is great, but we do need to know who their previous pharmacy was. And then is there any preferences with how they take their medications? We have one little lady who will only take her medications in raspberry jam. And so that's how she gets her medications. But it was a lot of trial and error to get to that point and discover that. And then particularly with coming from the hospital, you need to watch out for MRSA and VRE infections. And now that we're in cold and flu season, COVID is still very much out there. So we need to be aware of any recent infections and what the guidance would be from public health regarding all of that. And then any relevant immunizations as well. Then we get into the real person and family-centered care section. So I really like to learn about the person and get an idea of who they are. So that includes, their career, what they did for a living, any volunteer history, as well as formal education. I like the social background as to, is there any family dynamics we need to be aware of? Because families can be extremely complicated. Their religious or cultural beliefs and any practices that hopefully we can still provide for them or, start providing those services for them. Any pets? Do they enjoy cats or dogs? Would they like to see our therapy dog that comes in every week? Or is there any fears? Is there a history of trauma? Any fears we should be aware of? For example, are they fearful of dogs visiting the home? And then any likes or dislikes. So this could be foods, drinks, it could be knitting and puzzles, it could be drag racing. We had someone move in recently who loved drag racing. Is there anything they don't like? Any foods or drinks? Some people it's they're a very private person. So making sure that you're honoring that privacy as much as possible. And, they prefer that you knock and announce yourself before walking in, which you should be doing anyway, but be extra mindful in this case. And then we get into their goals. So what is important for them and what's important to their family? So we have someone moving in next week who is moving from 6 hours away here to be closer to family. So the real goal is that she won't be so isolated because she was really by herself, living independently there and was not coping well. So they're really looking forward to, reconnecting with the family and getting her less isolated. And hopefully we'll see some improvements in that way. And then is there any other things that we need to know to take good care of them? Do they have a fear of the dark and they need to sleep with the light on? And then is there anything else we can do to make them feel welcome? So I'll get into that a little bit more later on. And then, as I mentioned, we kind of finalize things in everyone who reviewed this tool and signed off on it. And then the director of care finalizes it and approves the admission. So after I have reviewed the application and accepted them onto the wait list, I like to mail out a welcome letter. And so it really just is that initial contact with the home. It provides them with my name and phone number so they can call me. I invite them for a tour. It has the list of what they need to bring upon admission and gives them a bit of a heads up that it can be a very quick turnaround between getting the bed offer and the move-in day. So it's good to be aware. I also include our commitment to abuse prevention brochure and our BPSO brochure. Then about 7 to 10 days later, I do a welcome call where I introduce myself, confirm that they got the welcome letter, invite them for the tour if they haven't come for one yet. And I typically spend about 30 minutes on the phone with the family or the resident at this time, going over their specific concerns and scenarios. And that's a really good opportunity to start that really good relationship on the right foot and start building that rapport. And then if they have any other questions or would benefit from extra resources, I can provide them then as well. Then we do that pre-admission care conference. So typically that's when I do all of the admin paperwork and then review all of my admission tool and make sure that we've got a really good plan of care in place. I provide them a move-in schedule so they know roughly, okay, you're going to arrive at 10 o'clock. You're going to do your meeting with this nurse at this time. She's going to do these assessments. And then it also has, what's coming in the next week, and that the recreational department will meet with them to do those assessments. The physician will see them within 2 weeks, things like that. I also like to get any clothing and personal items from them then so that they can be labeled and be there in the closet when the person arrives, and that the room is decorated nicely for them. It's just a very welcoming atmosphere that way. All of that information that we gather goes into the residence care plan in the My Care Plan section. So this is something that I do as social services, and it includes the part on their goals for care, their values, as well as their routine. Then on admission day, I like to meet the person at the door, take them for a tour of their room if they haven't seen it. And of course, everything is labeled with their name on it. Their name's on the door. Introduce them to their staff that are on the wing, the PSWs, the nurses, as well as their admission nurse. And then we have a welcome card and a gift for them, which we really try to personalize based on what we've learned about the person. For example, the lady in the photo there, very vibrant personality, and we do welcome quilts. So she received a welcome quilt, and she also worked as a cook and was very proud of her cooking and baking. And it's kind of hard to see in the little picture there, but there's strawberries on her quilt. And she was so thrilled to receive that. And she said, I have the best strawberry shortcake recipe. And she told it to me from memory, but she was so thrilled to receive that. And we were able to kind of explain why we picked it for her. So we really try to make that personal for them. And then, of course, we provide them with the activity calendar and a copy of the menu. And then the recreation staff take a picture of them for point-click care for their profile. And then the admission nurse does all of the kind of nursing and clinical side of things in their assessments on admission. And then we try to invite the family to stay for lunch, because typically by the time that we're done the heavy stuff in the morning from 10 till 12, then it's lunchtime, and then typically people need a bit of a rest after lunch because it's a very busy and can be a very overwhelming day. In the first month, after someone has moved in, that day one, I do a visit with them, and then I do a follow-up phone call to the family and just kind of let them know how the first 24 hours went. They slept well, they're already at exercise class this morning, they're doing great. Hopefully it's all good news. Our recreation team does their recreation assessment, and they complete an All About Me poster, which we put inside the residents' wardrobe so that the staff, the PSWs, the laundry staff, housekeeping are able to see it, and they can refer, and they're good conversation starters. And then the physician goes in within about 2 weeks to do their assessment. And then the dietitian and physiotherapist do their admission assessments as well. And then we schedule the admission care conference within 4 to 6 weeks after move-in to review holistically all of the different departments about what's been going well. Have there been any wrinkles we need to iron out? It's a really good way to make sure things are going well and to collect that feedback on the admission process. It hasn't been without its challenges, though. It is a very time-consuming process. Going through the applications with such a fine-tooth comb can take a long time. I had one application recently that had 150 pages worth of hospital documentation to go through. So it can take a long time. We have also had big changes with staff. And when we started this admission process, we were particularly short on nurses. So it was hard to try and pull someone specifically to do admissions. But we're doing much better with that now. It's really not an issue anymore, thank goodness. And due to the high number of vacancies that we had, we were doing a lot of admissions quickly to try and fill those beds. And sometimes we do run into some delays with Ontario Health at Home. We currently only have 8 ladies on our wait list for a female basic bed. So some of those people were really not expecting to move into long-term care yet. You know, they're really low on the priority level list. And so they weren't quite expecting it and might bypass, so that we're going lower and lower on that list. So sometimes waiting for the paperwork to be updated is a bit of a holdup. And then, of course, our home isn't without outbreaks, and we have to follow the direction of public health on admissions. Fortunately, things are getting better in that regard. It hasn't been a huge barrier lately. And sometimes there is communication barriers with regards to, when we're able to admit someone, oh, you're doing this, I'm doing that, making sure everyone's on the same page can always be a challenge. And since doing this, we've found that we're now in adherence with the Long-Term Care Act, Fixing Long-Term Care Act 2021. We're being proactive instead of reactive. We're not missing important information. We're really building a solid foundation of trust with the resident and their family, and the assessments are not as repetitive. The staff are knowledgeable and prepared for the admission, and that makes the process a lot smoother for the resident and for the family too, because it can be a very stressful time. We're getting really good feedback from our residents and family on the admission process, and it's been very, very successful thus far. In order to keep this momentum going, we are still ongoing and recruiting for other BPSO champions. As I mentioned before, we've got the orientation process where I go in and sit with the new staff and talk about BPSO. We have that team approach, so everyone has a role in regards to the admission process and making sure their piece goes smoothly. And we have built in an admission nurse into our staffing complement so that we're able to not pull someone from the floor that's not being pulled away to deal with emergencies or things like that. We do an ongoing audit of the admission process by day 21 after they've moved in. And then at our admission care conference, we gather feedback on how their experience was, anything we can do better. And we make sure all of the relevant communication is sent out to staff via email and at shift report. And we like to share our success stories too, because that's always what goes the furthest, is hearing those words from the residents and from their family. So does anyone have any questions about our admission process at this point in time?
We'll just give some opportunity if you would like to type a question there into the chat for Peri-Ann. Peri-Ann, just while our participants are typing their questions, and I thank you for that presentation. That was very insightful. And congratulations on your 5 different best practice guidelines. That's amazing. And your designation to come in March 26. I really love the hallway of heroes idea. I think that's such a great idea. And how you're highlighting your best practice champions. That's not only providing visibility, but it's also providing that motivation and momentum with your staff. And then as you're showing your residents all the great things that you're doing and the families and stuff, that's wonderful. And my other comment is I really love the sleep. and rest preference of having the ability to sleep in the morning and maybe not have to get out of bed for breakfast. So your home has come a long way, and I think that it's amazing just how you can really provide that person and family-centered care to them. So thank
Mhm.
you for that.